Dr. Fletcher, what made you decide to become a doctor?
Well, I had a lot of curiosity about medicine, and there were many movies in my day that dealt with some of the pioneers in medicine, and so I became very interested in it. And I actually was in the 6th grade in grammar school when I decided I was going to be a doctor.
Do you think your family had any influence on your choice?
Well, actually, when I told my mother I wanted to be a doctor, she said, "You mean a nurse?" And I said, "No, Mother, I want to be a doctor." And then she took me down to the family doctor's office and said, "Betty wants to be a doctor." And he said, "Why not?" So that changed her mind a little bit, and actually he ended up being one of my professors in medical school. He taught physical diagnosis.
Where did you go to medical school?
I went to medical school at Syracuse. The medical school at Syracuse at that time was part of the University of Syracuse, and I wouldn't have been able to go to either university or medical school if it hadn't been located in Syracuse, because there was no money. It was the Depression, and nobody had any money, and you couldn't get a job. And if you did get a job like babysitting, it would be like $5 a week. So I went to high school with the idea that I was going to become a doctor, and selected the courses that I knew I was going to need for pre-med in college, always with the hope that I would be able to go, but never knowing for sure, until actually I got into medical school.
How much did it cost for you to go to medical school?
It was $500 a year.
And do you think the increased cost of medical school today influence the choices of young doctors after they graduate from medical school compared to when you went to medical school?
Well, I know it makes a big difference in their lifestyle, because most of them end up with a big debt.
Yes.
And so when they come to apply for positions, they ask for a lot of money, because and most of them are married, whereas we weren't. We weren't married when we were in medical school, and we did not have a large debt because there wasn't any place where we could borrow money to go to school. And we depended on our families and scholarships in order to do it. And I know that it does affect lifestyles, but the difference between today and then was that then we all knew we were going to start out very humbly, and we didn't buy a house the first year we were in practice, and we lived a different lifestyle.
What year did you graduate from medical school exactly?
1941.
Okay.
And I got married 2 weeks later.
And would you care to share anything from your experiences during your residency or internship?
Well, I had a 2-year rotating internship, which started 3 weeks after I was married. I had a 1-week honeymoon in Boston, and then I came back and wrote New York State medical boards for 1 week, and the following week was the 1st of July, and I started interning. I had a 2-year rotating internship, and the toughest service I had in all the 2 years was the first 4 months, which consisted of neurosurgery, ear, nose, and throat, GYN, ambulance, alternating with any night calls every other night, which meant that any IVs, either intravenous or transfusions, anything that called for a needle was the intern's job to do it. So you were very busy, and you worked long hours, and you were on the next morning as well, so you didn't get off until 5 o'clock the following afternoon. And it was a very hot summer. Neurosurgery was the biggest problem because we worked under the lights and under glass light in the roof of the operating room, no air conditioning, and those surgeries were many hours long and very difficult. And then when the patient came back to the room, most times he would develop a high fever, and you'd end up taking him back to the OR and try to relieve the intracranial pressure. Anyway, it was very difficult, and I know that I would go home after a long service like that, and I would be so tired I'd just be bawling. My ankles would be swollen, and I was just totally fatigued. After that, the internship was relatively simple. I had help and with another intern, and it was certainly less difficult than that. The internship consisted of services in OB, infectious disease, surgery, internal medicine. And the 2 years were very filled with a lot of education. Following that, I spent 14 months in a pathology teaching fellowship at the medical school, during which time we had 2 classes, medical students go through the pathology course. And I did autopsies. I think I did hundreds of autopsies because we were short of help, and most of the ones I did alone, and they were not very easy because we had no air conditioning, there was nobody to clean up, and no power tools. It was a real experience.
So what did you choose as your specialty?
Radiology, diagnostic radiology.
And what made you choose radiology?
Well, because I like diagnosis. I never really cared much about treating patients. Not that I didn't like them, but I just didn't care for what it involved. Once the diagnosis was made, I was really, disinterested as far as what happened after that. And pathology was a very good preparation for radiology because I always thought of radiology as shadow pathology.
So what year did you start practicing here in Worcester?
47.
47. Could you describe a typical day when you first started practicing here?
Well, first of all, I came from Mayo Clinic. I spent 3 years out there as a fellow in radiology, where the volume of work was tremendous, and they were up to date on everything. And I came to Worcester, and I joined a small group, the Fallon Clinic, and there were 2 surgeons, 2 internists, and myself. And of course, there was very little. Some days there would be 8 radiology patients, so you can see I was pretty bored for part of the time. I ended up doing histories and physicals just to fill up my time. I had one technologist, and I quickly learned that I better learn some technique because if she weren't available, I was the one that had to do the technique as well as read the films. And of course, X-ray in those days involved darkroom processing of films. Did Dr. Janauer talk about that?
No,
Well, films were in cassettes, which were taken into the darkroom after exposure, opened. The films were put on hangers and put into developer, then into hypo, which fixed the image, and then into wash, and then into the dryer, so that it was at least half an hour or longer before the film was available to be read. Of course, we could always pull up the film in the hypo and in the wash to see how it was doing, but everything was done on by time, so that theoretically the film wouldn't be fixed probably for maybe 6 or 7 minutes, and then it would go into the wash and when you could look at it. And of course the wet plate was what everybody wanted. They wanted a wet reading, a wet plate. And of course plates were glass plates on which films were recorded during the war, but wet plates disappeared. Glass plates weren't used in my day, but we still talked about wet plates and a stat wet reading and all that sort of thing. But anyway, my day consisted of doing a 1 or 2 upper GIs, maybe a barium enema, maybe an intravenous pyelogram, a few chest x-rays, KUBs. That was and gallbladders. Those were the exams that we did.
Did your routine change at all over years of practice?
Well, the exams remained the same, but the methods and the techniques changed. So that when I started out, there was no image intensification in fluoroscopy, so the fluoroscopy image was poor, with a lot of penumbra and poor detail. But after I'd been in practice for several years, image intensification became available, and then the images were remarkably better and improved our ability to interpret the films.
What were the hours of your typical day like?
Well, when I first started, it would be like from 9 o'clock until 5. Later on, when we really grew, as we did, and I was alone at the clinic until 1973, part of my day was spent going down to Whitensville doing fluoroscopy and reading films down there. And then when I'd come back, maybe by 10:30 or 11 in the morning, then I would be confronted with a large group of patients who were staring at me because I wasn't there when they came. And anyway, it got to be very busy. In 1973, we added another radiologist, and then rapidly we took on several more, so that there were 7 or 8 radiologists by the time I retired.
Did you make house calls?
When I was a medical student, I did. Part of our pediatric service was making house calls on our pediatric patients. And there was a while when we did on medical cases too, and we did home deliveries, 13 home deliveries, babies, and had to make house calls after the delivery for 10 days. So that was my experience with house calls.
Did you ever use the telephone to talk with patients once you were done working at the hospital?
Not really, no, because radiology doesn't like that. They have no occasion to do that.
So who were your patients exactly? I mean, where did they live?
Well, they lived in this community, and we had patients that came down from Athol, and they came up from Whitensville, and some of the small towns around Holden, Auburn. Most of the patients were self-referred. There were a few doctors who referred patients to the clinic. There was a doctor up in Athol who referred a lot of patients to us. And we had a doctor or two in Auburn and Millbury and who did refer patients, but most of our patients were self-referred. We were sort of in competition with a private practitioner because this was group practice, and I never knew any other kind of medical practice except group practice.
What do you think it was like for your family to have a physician in the household?
I don't really know. My mother died when I was in medical school, and I never heard my father brag about having a daughter that was a doctor, so I don't know. I don't think, I think that he must have been proud, but he never let me know.
Did you ever have a vacation?
Oh yes, 2 weeks every summer.
So once you started practicing medicine, what made you decide to keep being a doctor? What did you really like about your practice?
Well, I just love medicine. And I practiced until I was, I think, 83 years old, and that shows you I really loved it.
Yeah. Do you have a favorite memory from your career?
Oh, not any specific, I don't think. Just the fact that the clinic grew, that was what I was so happy about, and the fact that we outgrew our first location and built a new building, and from then on, the clinic just expanded, and I don't know how many satellites there are now, but, you know, it's quite large.
Do you have any least favorite memories?
Well, I think the one that was the real shocker was when Dr. Fallon really almost dropped dead 4 years after I joined the clinic, and there were just 4 of us. And then it was a big decision. Are we going to continue as a group, or what are we going to do? And we finally bought the business out from Mrs. Fallon and continued on. But we practiced 4 alone until 1957, when Dr. Massarelli joined us. And he was Mayo trained. So that Dr. Manning, Dr. Massarelli, and I were 3 Mayo people, and there were some later that joined us, and at present there are 2 Mayo people at the clinic, Dr. Strobel, who was a pediatrician, and Dr. Persons, who was a dermatologist.
What were the typical illnesses of the 40s and 50s?
Well, when I was in medical school, polio was a problem, and there was a big polio epidemic while I was interning, and there were a few deaths. One particularly that I remember was a cervical polio, and a father of a family. His children didn't get it, but he did, and he died, and I remember we autopsied him on December the 8th, 1941, when President Roosevelt was speaking to Congress. We had the radio on in the autopsy room. But polio, and I saw a few cases of typhoid fever in Syracuse. They came down from St. Lawrence County every year in the fall. But I would say polio was the biggest problem and the most feared, because we didn't really know much about it. And there was no treatment except to make the patients comfortable, and if they had respiratory failure, they were in the iron lungs. But, and it was, you know, it left people with disabilities.
Are there any other illnesses you'd like to talk about? I remember you mentioned earlier about tuberculosis and
Yes, TB.
pneumonia.
Well, pneumonia was a serious disease. Lobar pneumonia had a very high mortality rate. I think it was something like 30%. And the patients were very seriously ill, and the illness lasted 2 weeks or more. And they went through a period called the crisis, when the temperature broke or it didn't, and they went on and died. And we had nothing to treat them with until the sulfonamide drugs came in, and then there was a dramatic change in the course of the disease. When the sulfonamide was started, within hours they were improving medical status improved immediately, but the course of their illness went on for approximately the same length of time because it took that long for the changes in the lung to clear. Some of them developed a septicemia and had complications like pneumococcal arthritis, pneumococcal meningitis, but mostly the cases I saw had a very favorable outcome, rather quick improvement. Tuberculosis was a disease which was serious and presented a public health problem. And when a patient was diagnosed with tuberculosis, the local health agencies immediately investigated all the contacts. They were required to come in and have chest x-rays, and the patient was required to be isolated. And most of the time it was isolated in a sanitarium, which was a publicly operated institution, and no other diseases were isolated or were treated in the tuberculosis sanitaria. Patient was admitted and could expect to be there anywhere from 2 to 3 years and longer if they did not respond. The only treatment we had was bed rest and forced feedings, and pneumothorax was treated. Air was placed in the pleural space to collapse the lung, thinking that it would provide rest for the involved portion of the lung and thereby promote healing. There's some question how effective it was because those lungs really never provided very good function once they were re-expanded.
How did the typical illnesses that you saw change in subsequent decades?
Well, the main thing was the development of the sulfonamides, followed by penicillin, the antibiotics, and then everything changed dramatically. One of the diseases that was a killer in the early days was appendicitis, because frequently the patient didn't present himself to a physician, or the physician didn't recognize the problem, and the appendix would rupture. The patient would develop peritonitis, and there was no treatment for peritonitis because we had no antibiotics. Once antibiotics were available, then peritonitis wasn't the killer that it was originally, but it's still a serious disease.
So what was one of the most important breakthroughs in disease treatment during the course of your career?
Antibiotics.
Okay. How about in disease prevention?
Well, particularly with tuberculosis, the fact that people lived under crowded conditions and large numbers of people in a dwelling, the exposure rate was pretty high, and people with improved financial with improved finance and with improved salaries, and people didn't have to live under those conditions, and so that there was less exposure. of course, when in my day, when I was a child, if you came down with diphtheria or scarlet fever, measles, you were quarantined. The city came and put a quarantine card on your house, and you were quarantined for however long. And I think it was like 4 weeks or more. I know my father moved out when we were quarantined, and the rest of us lived there alone, except the doctor would come and go. But that was how isolation was affected, and the sanitarium was the isolation for the tuberculosis patients. And there was no choice. I mean, you know, there wasn't any consideration about your political rights, particularly with tuberculosis. You didn't have a choice. You went to the sanitarium, and it was enforced. We know more about diet and vitamin deficiencies. We know about insulin for diabetes. We know about vitamin B12 and B6 for pernicious anemia. Those were things that all more or less developed in my day. People that had diabetes, like type 1 diabetes, they died because there wasn't anything to do for them until there was insulin. And people with pernicious anemia also died because there really wasn't anything for them either.
Were there any other drug changes that you saw throughout the course of your lifetime?
Well, I'm not a very good one to talk about that, because since I never really practiced internal medicine, I really wasn't aware. Once I got out of my training, I wasn't aware of what changes there were in medications. We learned a lot about the causes of disease. Like one of the killers was hypertension. And during my day in medical school and internship, there wasn't any treatment for hypertension. And people didn't realize the connection between sodium and hypertension. And my mother was a hypertensive, and one of her favorite treatments for her arthritis was lemon juice and baking soda in hot water in the morning. And, you know, that did not help her hypertension. Trying to think of other diseases where, of course, digitalis was available, but I don't know how long we knew about digitalis, but that was a help in congestive heart failure. But there was very little you could do for patients with hypertension and failing heart in those days. And it's only relatively recently that we have medications now to manage hypertension.
Okay, could you just briefly comment on attitudes towards smoking and cancer throughout the course of your career?
Yeah. All the movie actresses and actors smoked. We all went to the movies. That's about the only entertainment we had. And Betty Davis smoked, and by gosh, we were going to smoke. And I started when I was in high school. My sister started before that. And we smoked for many years. In 1940s, late 40s and 50s, there was a guy by the name of Everett Scram out in St. Louis who was writing papers about the relationship of cancer of the lung and cigarette smoking. And I read those, and I thought, I wonder if I shouldn't quit. And my sister, who was a pack-a-dayer, I talked to her. And the two of us quit. I think it was in 1951. Her husband smoked 3 packs a day, and another brother-in-law of mine smoked 3 packs a day. We all quit cold turkey right then. in around 1951. I found out later that Dr. Graham, who was giving the papers, had a cigarette hanging out of the corner of his mouth when he was giving them, and he died of cancer of the lung himself. But people today can't believe that we knew back that far that cancer of the lung was related to cigarette smoking. They mean, oh, you don't mean 51, you mean 61, 71. No, I mean 51.
How did patients without money get health care when you were in medical school, when you started practicing medicine?
Syracuse Free Dispensary. The local communities picked up the cost. They paid for indigent patients. They paid for their hospital room beds, and they paid for their care at what we called the free dispensary. And it was an opportunity for medical students to learn, because those patients were available to us to do histories and physicals on, to treat, to examine. And that was how it was done. During the Depression, Blue Cross began in Syracuse, Onondaga County. I don't know much about it, but I know it was developed at that time. But I had no contact with it. I had no knowledge of how it really worked. I just knew that some of the doctors I knew were working on it, developing it. When I was practicing early at the clinic, we had both Blue Cross and Blue Shield, and Blue Shield paid for the physician's expense. Any examination, like an upper GI or a gallbladder or a colon, would not be paid for in the doctor's office. Those patients had to be admitted to the hospital in order to have Blue Shield pick up the cost. And it took a while for that to get straightened around, and I know it affected us, because if it hadn't been for Blue Shield paying for office practice, I don't think the Fallon Clinic could have developed as it did, because we had a lot of money was on the books when Dr. Fallon died. Patients didn't pay their bills. They didn't have any money. So that at least we got whatever Blue Shield paid for toward an exam. And so I've always believed that the Fallon Clinic succeeded because of Blue Shield.
So do you believe that everybody who needed care received it when you practiced?
That probably isn't, I don't think so. I don't know. All I know is that we had a private practice there. Some of the doctors did a lot of work for free. And of course, we always took care of any doctors and their families, and the priests and the nuns. They all were for free until everybody carried health insurance, and now everybody pays. Doctors charge doctors, and doctors charge priests, and doctors charge nuns, and
But of course, during your childhood and throughout the early part of your career, did you find that many people simply chose to stay at home to treat their ailments instead of go to the hospital?
Well, it was the doctors who indicated what was done, and if the doctor didn't say you had to go to the hospital, you went to hospital for a tonsillectomy, for an appendectomy, or any, like a cholecystectomy, for surgery. But most of the medical conditions, a stroke you might, but even people who had cerebrals were treated at home, and they died at home. So that the hospital wasn't that important in the care of a patient in my day, early days. Traumatic cases went in the hospital, industrial accidents, automobile accidents, any type of injury of any significance was hospitalized. They had infectious disease hospitals, like and rather than being quarantined at home, you could be admitted to the infectious disease hospital. Every community had an infectious disease hospital for scarlet fever, for typhoid, polio, whooping cough. That was another killer, whooping cough.
Throughout the years, how do you think Worcester compares to other places in terms of providing care for the underserved?
I don't know.
Okay, because you've only practiced in
I
Worcester.
can't tell you.
What were some fears and concerns about socialized medicine in the 50s and 60s?
Well, it was a bugaboo. Everybody was concerned about socialized medicine. And I don't know, you just went along from day to day. I know there were people who were dedicated to bringing in socialized medicine, but it just gradually developed. I mean, we certainly have a form of socialized medicine now.
Were physicians involved politically on the topic of socialized medicine?
I think some were, but I wasn't. It was mostly, I don't think it was so much the physicians themselves. I think they were more, unless they were institutional doctors, the ivory tower people, you know, the profs and professors and like that, but certainly the people that were out in private practice, they were all rugged individualists, you know. Doctors were their own bosses. I wasn't quite a part of that because of being in group practice my whole life. But I met a few doctors from the West who were adamant about their rights and how they wanted things to be, and it kind of astounded me. I didn't realize that the doctors were that individualistic. But having trained at Mayo, which is group practice, it was the only way I knew, and to me it was the most ideal way because you had the advantage of multiple brains with the same patient. If you had a problem, I know the way we worked, if one of the internists picked up a problem in a patient, he called one of the surgeons, and the surgeon was right there. He came right in, and the whole case was settled right then and there. I mean, you didn't have to travel across town or any place else to find out what was going on and what had to be done.
As managed care came along with Medicaid and Medicare and HMOs, how do you feel that physicians and then patients and generally people's access to care were affected?
There again, I don't know exactly, but to the jump between group practice and managed care is, I mean, you know, you just don't realize it happened. It was almost the same, you know. We just went from being a private practice to group practice. And it didn't really affect, as far as my work was concerned, it didn't really affect it.
Do you think patients were affected? Or how do you think?
I don't know. All I know is that senior plan is a terrific, I will just ignore it. I have a recorder out there.
Senior plan.
The senior plan is a tremendous advantage for older people because they get so much. They get the finest care. Their pharmacy expenses are reduced, and it really is ideal for senior people. And I'm on a senior plan myself, and I know what a terrific thing it is and how limited my pharmacy bills are compared to some of my friends.
When did the HMOs first start to impact your practice?
I would say, and I'm not sure, but I think in the 60s, Dr. Myers was John Myers was the influential person there, and he was interested in health plan. But I know that the federal government said that we had to have a senior plan before we could have a, 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 a regular health plan. And they helped finance the senior plan at the beginning. That was only for a few years, like a couple, until we got established. But I think it was in the late 60s and 70s. But we were one of the first, you know, the Fallon Clinic with a health plan in this area.
What are some positive and negative aspects of HMOs?
I only know the positive. I don't know. People talk about the fact that physicians are limited the amount of time they can spend with patients. I've never seen any of that. I mean, the patient walks in and he's treated the same no matter whether he's a senior or a young person. It doesn't make any difference. I mean, if you're practicing medicine, you're practicing medicine. And I wouldn't stay with a group that said you can only do this and do that, you know. And the doctor who takes care of me, there's no sign. None of the doctors that of course, you can say I'm a privileged person, but I see no evidence that they're harried or that they are forced to limit the time they spend with people. I don't see it, and I don't think our group does. The main thing that you do have to worry about when in group practice is outside referrals. If your doctors in your group refer your patients outside of the group for conditions that can well be managed in the group, you can rapidly go broke, you know.
Yeah.
But there are certain services that you can't possibly supply. I mean, you don't have enough chest surgeries, you don't have enough brain surgery, so that you have to refer some of the, but for those conditions which you supply the physicians for, you can't afford to refer patients outside the group.
How have doctors' salaries changed over the course of your practice?
Well, I made practically nothing for many years. I would say, at least in our experience, as we grew as a group and produced more income, the salaries were increased accordingly. They are definitely limited to, in comparison with what the private practitioner gets, because there is no control over what he makes other than how hard he wants to work. Whereas in group practice, it doesn't matter what your specialty is or how much training you've had or anything of that variety. It's determined by how much there is there at the end of the year to pay the salaries. And there really isn't that much consideration given to the intricacy of the specialty. And consequently, group practices have a hard time hiring certain specialists because they can do much better in private practice.
How has malpractice insurance changed over the years, as well as the impact on doctors' practice?
Well, it's just become exorbitant, really. Certain of the specialties, like OB/GYN, neurosurgery, anything connected with surgery, you know.
Yeah.
And the settlements are such that, you know, they're inordinate, some of those settlements. I think it's going to change, but we all knew, like I can remember when I was a senior in medical school, a lawyer was talking to us. He said, don't open up a practice without malpractice insurance. But then those days, you know, it was like maybe 2,000 a year, something like that, for most specialties. And people weren't, you know, so conscious. Malpractice was not as malpractice suits weren't as common as they are today. I mean, people today expect a cure, you know. No matter what they've got, they expect a cure. And they expect the doctor to provide it. And there are some cases that you can't provide a cure, and sometimes you can't even avoid a bad result, you know. But I think that's going to change because there's going to be a limit put on the amount of settlements, I think. I think the government's beginning to pay attention to it. And for instance, Canada, they don't have the malpractice suits up there. There's a limitation on what you can collect, and they definitely have a entirely different malpractice program up there than we do.
How did you learn the business of medicine?
I really didn't. You see, that's one of the advantages of group practice. There's an office that does all of that for you. They make out the insurance forms, they send out the bills, they do everything, so that the doctor in group practice is really is alleviated of any obligation like that. But I did, you know, when we were struggling to make the four-man group succeed, I was sending in a lot of insurance forms and that sort of thing. But as soon as we began to grow and the office became more effective, that was no longer anyone's duty. That was done by the office.
What are some changes that you've seen in the demographics of the Worcester community?
I don't really know anything about that.
Okay. Did the ethnic background of your patients change at all over the years? Did you notice anything?
I think so. We have a lot more Latins, for instance, than we did, and I think we have people that are interpreters, which we never had in my day. I mean, we learned a few Spanish words, you know, when you were examining a patient, and could get along like that. But, so I know the clinic has provided interpreters in various languages, but the main one is Spanish.
How has women's health in Worcester changed over the course of your practice?
I don't know. All I know, we get mammograms yearly. That's all I know.
Yeah.
I think that's one of the main things as far as women are concerned. Almost everybody's aware of cancer of the breast. And I think that's one of the big things. And of course, birth control, hormone therapy for menopausal, postmenopausal women. That's changed, but not being in, you know, internal medicine or OBGYN, I really am not too aware of, but I do know about the effect of mammograms, and we do a lot of them at the clinic. Tremendous number of mammograms.
Could you comment at all on changes in children's health care?
Not really. Of course, all the inoculations they get during their childhood, early childhood, has done away with whooping cough, which was, as I said before, a killer, and measles, tetanus.
What were public perceptions of doctors early on in your career?
Well, they probably were second to the priest. If you had a problem in the family, where'd you go? I know it didn't matter what it was, financial, you know, anything, right down to the family doctor. And he was not reluctant to give you advice. He was always helpful. He was like a father in the family, really. And when he came to the house was spick and span, and you ran around, what did he need? Anything, you know.
Yeah.
It was always very impressive.
How do you feel that public perception of doctors have changed throughout the course of your life?
Markedly, markedly. People are critical. They assume they are better informed than the doctors. Some of the doctors tell me it's very difficult to practice today. They run into objections no matter what they want to do. And of course, we never had a problem like that. If we said take 2 ounces of castor oil, they took it, you know. But now you get an argument for everything because they know from what they've heard on TV that doctors aren't supposed to be trusted. The lawyers are there. Now, if you have a problem and somebody died of some condition, maybe we could sue them, you know. That's one of the big things. Did I do some damage?
No, I don't think so.
Okay.
Are there Worcester physicians that you admired when you started practicing?
Well, I admired Dr. Fallon. Of course, he was the boss. It was his clinic, Dr. Fallon's clinic. We all worked for him on salary. I admired some of the radiologists, Dr. Elliott, Dr. Lingley. I thought they were very good men. I didn't know many of the others, really. My own partners, Dr. Brosnan, Dr. Myers, Dr. Manning, I thought they were great.
But you just didn't know too many other doctors in other fields aside from radiology?
Not really, no. I knew a couple of the Mayo-trained people like Jim McCann, and I certainly had all kinds of, anybody that came from Mayo to me was okay.
What was it like for the female physician in Worcester over the 50s and 60s and 40s?
Well, I don't really know. There were a few women doctors here in town when I came. I never knew them. There was a woman radiologist that I got acquainted with. I don't know what became of her. She didn't remain too long, I know. I never had any problem as far as being accepted in my own group, but there were some objections, but I don't think it had to do with the problem of being female. It had to do with the politics of medicine in general. And I don't think I want to go into it.
Okay. How did group practices or hospitals treat blacks and other minority physicians when you started practicing?
Group practices. Well, there were no blacks, really, in Worcester. We didn't have any black employees, and we didn't have any black patients. We now have both, you know. But I think it was mainly the fact that there were so few blacks in the city of Worcester that we weren't aware of a problem, you know. And like in Syracuse, when I was interning, there were some black nurses who came to Syracuse because they were tied to an army regiment that was stationed there that was black. And some of the indigent patients refused to have a black nurse take care of them. I know that.
What did you like best about practicing here in Worcester?
Well, I like New England, mainly. And the medical school, UMass Medical School, made a tremendous difference in the quality of medicine practiced in the Worcester area, I think. I wouldn't have been here if it weren't for my husband. My husband was in business and he needed to be in a populous area. He said, if you want me to be home, we better go to someplace where there are some people, because like out in Minnesota, it was long distance between he was out 2 weeks at a time is what I'm saying. So that, you know, so New England was perfect for him. And I love New England and the ocean and all of that, which I certainly didn't have in Syracuse or in Minnesota.
Is there anything that you like the least about practicing here?
Not really. I liked what I did. I liked the people I did it with. And, you know, I feel I was very fortunate.
Well, obviously, Dr. Fletcher, there have been many changes in medicine, and it's a growing field, and it will always be a changing field. How have you found yourself keeping up with the changes in medicine in terms of education over the course of your career, like right after medical school and even in the later part?
Well, when I first started practice, I went to national meetings. I always went to the Radiologic Society of North America meeting, and it was usually in Chicago. I went every year. New England Röntgen Ray Society, one of the best radiologic societies in the country. I belonged to that, and they met monthly. And that was how I kept up in those times. But then as I got older, and I mean older, I mean beyond 65, I used to do home study programs. The state passed a law that you had to have so many credits from either attending meetings or home study courses, grand rounds, in order to be relicensed every 2 years. You had to have a certain number of credits. And so I participated in that and did a lot of home study programs, and those involved the material plus an exam. And that's how I kept up when I no longer felt I was able to go to meetings, because they are a chore, going to meetings. Because they're big, they're usually in one place, and your accommodations, your hotel accommodations are elsewhere. So there's a lot of communication, and it's usually in bad weather, cold weather, and it's tough on an older person. But when I was younger, I looked forward to it, you know.
Well, before we wrap up our interview, would you care to comment further on how your specialty of radiology has changed in general over the course of your career?
Dramatically. I mean, we had very little facility in my day. There was no interventional radiology. And of course, in office practice, there isn't anyway. There is now a little bit, but, and we had only the X-ray to provide us with information. One of the first things that helped the radiologist a lot was the use of endoscopes, endoscopy. You know, upper GI endoscopy, colonoscopy. All those things provide a tremendous amount of backup for the radiologist. The improvement in the equipment, I mean the image intensification in fluoroscopy particularly was a big help. Then came tomography, which is body section radiography, and then it became digitalized with CAT scans, and then nuclear magnetic imaging without the use of X-rays is a tremendous help. And sonography, the use of sound to develop images. So that the production of images has changed a lot since when I started. Because we had only the X-ray machine, plain films, you know, and now, and the information that's provided by CAT scans and nuclear magnetic radiation imaging is fantastic. I mean, it's almost like textbook pictures, you know.
Would you care to comment on changes in medical education from when you went to medical school to medical school now, and maybe what changes there should be in medical education in your opinion?
I don't know much about that subject.
Okay.
I think there's one thing that I think we need to do a better job with is treatment of old people. Geriatrics is a coming field, and it should be growing faster than it is, because the older patient is different from the younger patient, both in response to medication, attitude of the physician, and they are promoting long life by, you know, restricting fats and all this stuff. They try to make you live longer, but then if they don't take care of you once you get there, you know, it's not going to work out very well. And I mean, so many doctors say, well, it's your age, no matter what you tell them, it's your age, rather than getting busy and checking out what is causing the problem, you know? So being an old person, that is one of my criticisms. And I don't care what institution you go to, that happens. It's so easy for a doctor to say, well, it's your age, you know?
And lastly, what advice do you have for younger doctors?
Well, have a personal interest in your patients. Really try to be personally interested in their care. And if you feel as if you can't care for them, refer them to somebody else who can and will. I mean, there are personality conflicts and that sort of thing that really shouldn't be a barrier to good medical care. And I think, you know, a doctor has to have a lot of heart. I don't think they can be a doctor if they're just in there for the buck, you know?